Hello, everyone, and welcome to the Multiple Sclerosis Association of America's live webinar, Understanding MS Progression, the Importance of Treatment Adherence. My name is Peter Demiri. I am the Vice President of Programs and Services for MSAA, and I will be your host for tonight's program. I'm looking forward to having a great presentation and very honored to have a top MS expert here tonight to present on this critically important topic. At this time, I would like to introduce our guest presenter, Dr. Carrie Hersh. Dr. Hersh is an MS neurologist and Assistant Program Director of MS Health and Wellness Initiative, Mellon Program for Multiple Sclerosis at the Lou Ruvo Center for Brain Health, Cleveland Clinic in Las Vegas, Nevada. Dr. Hersh is also a longtime presenter for MSAA and part of the steering committee for MSAA's Navigating MS initiative. Dr. Hersh, thank you so much for being here and welcome to the program.
Thank you very much for having me.
I would also like to thank the supporter of tonight's program. Tonight's webinar, along with other recent educational programs on treatment adherence, is made possible through the support of Sanofi Genzyme. Just want to take a moment here to touch on MSAA's programs and services. As many of you may know, MSAA's mission is to improve lives today, and we do that through our free programs and services. Listed here are just some of the many services we offer to the MS community, and we invite you to visit our website at mymsaa.org or give us a call at 1-800-532-7667 to learn more. And for tonight's webinar, we'll have a question and answer session at the end. So we invite you to submit your questions in the chat box that's on the screen. We do ask, though, that you keep your questions general in nature so they can apply to the group, and we will hope to dedicate the last 10 minutes or so of the program towards Q&A. I will collect the questions as they come in and try to get them all at one time to Dr. Hersh at the end. On the technical side, if you're experiencing any technical problems with the webinar, you can also use the chat box that we just spoke about and type in your issue. We do have an online moderator with us for the entire program, and that person will respond to your chat and help correct the problem. And please know that this webinar will be recorded and archived soon on MSAA's website. So at this time, I am very happy to once again introduce Dr. Hersh and ask her to begin the program.
All right. Thank you very much, Peter. And I'd like to first thank the organizing committee for allowing me to speak about this very important topic tonight. My overall goal for the program is outlined on this objectives page. First, I would like to make sure that I'm providing to the group a thorough understanding of MS disease progression, what that means, and what are some long-term consequential sequelae of that. We also want to make sure that we are identifying common challenges and barriers for non-adherence, and then, of course, being able to highlight important research that is showing the importance of MS treatment adherence and why that it's critical for long-term MS health. And hopefully, by the end of the program, we will be able to better offer effective strategies that will offset some of these barriers and help maintain treatment adherence so that the person who is on disease-modifying therapy will overall have a better long-term outcome. So before we start talking about what it means to be adherent to medicine and why that it is so important, why don't we go ahead and step back a little bit and talk about what is multiple sclerosis, the common etiology and pathogenesis of multiple sclerosis, because that is very important in understanding why treatment adherence is so important, reviewing the classification of MS because there have been some recent changes in how we classify the clinical disease course, and this way we'll all be able to be on the same page before we move on to disease-modifying therapies and the importance of treatment adherence in preventing progression of disease. So multiple sclerosis is an immune-mediated disease of the central nervous system that is characterized by several different pathological changes. It is considered an inflammatory demyelinating condition where there is actually local destruction of the myelin, which is a protective insulation around a wire that allows for neurons to communicate with each other in the brain and the spinal cord. But it is also described from axonal loss, damage to central nervous system resident cells, which are our keepers of the immune system, and eventually neurodegeneration when there is dying back of nerves, when there is extensive demyelination in a particular area in the brain or the spinal cord. Previously, it was once believed that multiple sclerosis was primarily a white matter disease, but there has been a lot of extensive research showing that it is not just a white matter disease. It actually does impact gray matter pathology in both the brain and the spinal cord, which are very important in MS pathogenesis and the overall treatment strategies of our disease-modifying therapies in preventing progression of disease long term. And there is some belief that the subtypes of multiple sclerosis may actually be due to different underlying immune mechanisms and pathophysiology. So a very common question that I get in clinic is, well, doctor, what causes MS? Why do I have MS and no one else in my family has MS or any other autoimmune diseases? Well, at this point, we don't know exactly for sure what causes multiple sclerosis, but there is a general understanding that there are different mechanisms at play in a sophisticated and complex array of triggers. So what we do think is that there is a genetic predisposition to developing MS. And while we do not know the exact genetic mutation that is involved, we do believe that there is an important component called the HLA-DR2 chromosomal location. And it is thought that a complex array of genetic mutations in this area may actually predispose somebody to developing MS with the appropriate potential triggers. And so what are those potential triggers? Well, some of them are viruses, and there's been a lot of talk regarding the Epstein-Barr virus. Vitamin D deficiency may also play a strong role in the potential trigger of MS in someone who is genetically predisposed. We do understand that tobacco smoking may also be a potential trigger, in addition to salt, obesity, and there has been a lot of provocative talk and research around the gut microbiome and how the immunology regarding the gut microbiome may actually be sophisticatedly regarded in the pathogenesis of multiple sclerosis. And there is a complex interplay with the immune system. So there are two key areas of the immune system. So we have the innate immune system, and then there is the adaptive immune system. And the innate immune system is our first round of soldiers who are surveying the landscape and making sure that our bodies are safe from things that don't belong, such as infections. Viruses and bacteria are certain examples. And when these soldiers start to go rogue, meaning that they start becoming confused and they no longer are able to identify and discriminate self from non-self, they start to hone in and activate the adaptive immune system, which are our T lymphocytes and our B lymphocytes. And when the T lymphocytes and B lymphocytes are activated, and they are able to cross over through the blood-brain barrier into the brain and the spinal cord, they may actually provocate disease through the demyelinating mechanism. So there is a complex interplay between our genes, between the environment, and between the immune system that creates an environment that begins the onset of MS disease pathogenesis. So kind of what I was getting to before is this activation of the immune system in the periphery. And what do I mean by that? Well, when you have an immune system that is no longer able to discriminate self from non-self, meaning that you have your soldiers, which are your white blood cells, that start becoming confused and start looking at self as the enemy, what happens is that these white blood cells are then activated in the peripheral system, specifically the blood. And in someone who has multiple sclerosis, these activated white blood cells, such as the T cells, are then able to cross through the blood-brain barrier and start launching attack on the myelin and the nerve fibers. And this is actually a very complex interplay between different white blood cells, members of both the innate immune system and the adaptive immune system. And then there's kind of this complex snowballing effect where these activated white blood cells are then able to call to their neighboring white blood cells, the neighboring soldiers, and they start releasing inflammatory cytokines and chemicals that further lead to demyelination of these nerves and eventually allow these previously very efficient communication pieces to become very choppy and very ineffective. And depending upon where that damage is done in the brain or the spinal cord will lead to certain symptoms and disability long term. So multiple sclerosis is an inflammatory disease, and this is a picture. This is actually a hematoxylin eosin stain. So this is a microscope picture of a surrounding venule, which is this area right here, and then this infiltration of white blood cells, which is all of these purple cells lying around the venule. And specifically what you are seeing right here is an MS plaque. And so what happens is that these activated white blood cells are actually able to cross into the blood-brain barrier through these venules and create this MS plaque. And we can see that this is the beginning of what we describe as an inflammatory demyelinating plaque that we can see on the brain and spinal cord MRIs. So what does this lead to? So I'm going to show you a couple of cartoon pictures here. This cartoon picture here is what a normal neuron looks like. So here we have the body of a healthy neuron, and here we have the axon surrounded by this myelin sheath that is colored in purple. And what happens in a normal neuron, in a normal passage of electrical conduction from one neuron to another, that's how they communicate with each other, there's actually what is called the saltatory conduction of electrical signal that very efficiently is able to get down from the body of the neuron to the dendrites of another neuron, so that the passage of chemicals between them allows them to talk to each other efficiently. And this is a very nice normal system. However, if we get to a disease system, specifically through multiple sclerosis, what happens is that that myelin sheath is then degraded by those peripherally autoreactivated white blood cells. And so what we can see here is an example of what that conduction looks like. So we can see that it's a lot slower than it was over here. And that's, kind of how the nervous system is acting in someone with a diseased central nervous system, that the passage of that electrical signaling is much slower, much more inefficient than it used to be. And depending upon where that damage is occurring in the central nervous system will manifest as different kinds of symptoms. So MS is also a neurodegenerative disease. So we went over how it is an inflammatory disease with the infiltration of the white blood cells into the brain and the spinal cord, how it is a demyelinating disease, and that once those white blood cells are able to traverse into the central nervous system, they start to degrade parts of the myelin sheath that allow for inefficient conduction of electrical signaling. But then it is also a neurodegenerative disease, meaning that over time there can actually be a dying back mechanism of these neurons where it's not just that the electrical signaling is slow and inefficient, but the electrical signal is cut off altogether. And so I kind of equate that to an analogy of playing telephone with two styrofoam cups and a string that connects those two styrofoam cups. So if you start shredding little by little that string, you're probably not going to be able to hear your partner on the other end of that styrofoam cup very well because that connection piece is starting to fray off. But if you cut that string altogether, then you will not be able to hear your partner at all. So that's kind of similar to what is going on with a central nervous system that is eventually degenerated by the multiple sclerosis disease. And there's accumulating evidence that suggests that there is an increased energy demand of this impulse conduction along an excitable demyelinated axon and a mismatch with a reduced amount of energy that is available for that system. So if you have a system that is demanding a lot of energy, but that energy is not available, there is this chronic state of what we call virtual hypoxia in a chronically demyelinating axon that starts to occur, meaning that the central nervous system is no longer able to meet the demands of what it is requiring, and therefore there is this unmet need and a dying back of the neurons because of that unmet need. And there's thought that if we're able to develop neuroprotective therapies that actually target that mechanism, it might constitute an effective adjunct to the currently used disease-modifying therapies that we have available. And this would certainly be something very interesting to look at in something like remyelinating axons as a neuroprotective and neuroreparative agent. So I had alluded in the previous slide that there has been this reclassification of multiple sclerosis. So previously, neurologists and other healthcare providers were classifying MS based off of a clinical presentation alone. And you would hear these constructs such as relapsing remitting MS, secondary progressive MS, primary progressive MS, and progressive relapsing MS. Well, we still use some of the terminology, but we're trying to reclassify exactly what this means so we can better tailor treatment for our patients who actually have disease. So instead of just looking at it as relapsing remitting versus secondary progressive versus primary progressive, we're reclassifying them as a relapsing form of MS versus a progressive form of MS. And with this new indication with relapsing forms of MS, we are hoping that we will be able to identify patients who clearly still need a disease-modifying therapy because they're still having inflammatory disease activity superimposed on their more gradual decline over time. And this is also another way that we can also get back to the insurance providers and say, hey, this patient actually is still having an inflammatory disease on top of the superimposed progressive disease course. This person still needs a disease-modifying agent. So this is reflexively looking at patients who still need to be treated with a disease-modifying agent. Progressive forms of MS really is just describing that in the background there is a gradual accumulation of disability over time outside of residual accumulation of disability from relapses. So this tends to be more slow, more insidious, more progressive over time. And that can include patients with secondary progressive MS without relapses, or what we call purely progressive MS, meaning that there aren't any new MRI lesions, there aren't any new clinical attacks that we also call flare-ups, exacerbations, or relapse. That this is someone who is simply slowly progressing over time. And then there is primary progressive MS, which is essentially a terminology for someone who develops this progressive disease from the onset of MS without having a relapsing remitting disease course in the beginning. But patients with primary progressive MS can still have periods of inflammation, active inflammation, including new disease activity via new MRI lesions on the brain and the spinal cord, and some of them can actually be enhancing with gadolinium, which suggests that they're still having these periods of inflammation, regardless of the fact that from a clinical description, they are progressive on the long term. The terminology of progressive relapsing MS is more of an antiquated term that we're not really using so much in clinical practice, and is really still considered a form of primary progressive MS. So what does this look like? So in 1996, we had this old description of criteria, very similar to what I was alluding to in the previous slide. So we would call something progressive disease, specifically meaning that the person in the background has a very slow, insidious decline over time in their current function. And we use mobility as a common and easily measurable disability outcome. But then you have primary progressive MS, you have secondary progressive MS, and then this more antiquated term of progressive relapsing MS. And that really is describing this insidious decline either from the get-go in primary progressive MS or after a very typical relapsing remitting disease course in secondary progressive MS. But now, after 2013, we have revamped this classification system so we can better describe what these people look like who actually have progressive disease. So it includes patients with primary progressive MS and secondary progressive MS, but what we are also trying to better define is whether or not they're considered active, meaning that they have new inflammatory lesions on their brain or their spinal cord, or they have new clinical relapses going on top of the slow decline over time. That is considered active. And whether or not they actually are continuing to slowly decline. Do they really have a progressive nature of the disease where the person over time is graduating from a cane to a walker to a wheelchair, or do they have what we call a progressive disease course that is not currently active, meaning they have no new relapses, they have no new MRI lesions, and they're not really progressing. They're actually quite stable in their overall disease course. And this is where we would indicate that this person actually has stable disease. So with this new criteria, we are better able to determine which patients still need to be on a disease-modifying therapy, and perhaps which patients may still benefit from enrollment in a clinical trial specifically looking at progressive MS. So this is an overall view of what the natural history course of multiple sclerosis looks like. So in the very beginning, called the preclinical phase, before a person even knows that there's anything wrong or going on, there is the development of brain MRI or spinal cord MRI lesions that are very characteristic looking for MS. And then over time, the person has their first clinical episode called clinically isolated syndrome, which is the first manifestation of their multiple sclerosis. And that can manifest in many different ways. Some people have something called optic neuritis, which is painful visual loss in an eye, or they may present with a transverse myelitis, meaning that they have a spinal cord lesion that is causing numbness, tingling, and maybe bladder and bowel dysfunction. And then after that, if a person remains untreated, they continue to accumulate new MRI lesions on the brain and the spinal cord, and then they continue to collect disability over time, with residual deficits from relapses that occur. So in the beginning, the person may actually resolve completely, where they feel back to their normal. But over time, after these clinical relapses during this relapsing remitting phase, they may have some improvement in their symptoms, but we can see that they are not returning to their baseline and they're slowly accumulating disability over time. And then after some critical threshold where the person is unable to appropriate a self-healing mechanism, the person then starts to accumulate disability more slowly over time with or without relapses, which are being described here by these little humps. And we can see through this red line right here that there is a slow accumulation of disease burden over time, which can manifest physically, but it can also manifest cognitively, emotionally, and psychologically. And very important from the get-go, even before the person starts to manifest any symptoms of MS, when they still are just developing MS lesions in the brain or the spinal cord, we can see that there is a slow decline in brain volume over time. And it's really important for us to try to intervene as early as possible so we can maintain the brain reserve and the cognitive reserve as well. And we can see here in the natural course of multiple sclerosis, about 50% of patients with relapsing remitting multiple sclerosis progress to secondary progressive MS within 10 years of disease onset. So this is why it's important that we do our very best to identify and diagnose patients as early as possible with MS so we can start treatment early. My apologies, I'm having a little bit of trouble with getting to the next slide. Oops. Okay, 1 second please. Okay, this is where I left off. My apologies. So what we can see from this slide here is really just a summary of what I had talked to you about in the previous slides. So what we can see is that over time, we can see that in the beginning there is much more of a disease burden in terms of inflammation. This means new MS plaques that are developing in the brain and the spinal cord that may or may not be leading to clinical manifestation of relapses, attacks, flares, exacerbations. They're all synonymous with each other. And then over time, there can be an accumulation of disease burden, but it's really when we start getting into the neurodegenerative phase, and this is about 15 to 20 years down the line from the onset of MS symptoms, where we really start to see the dying back of these neurons that eventually lead to more progression of disability. And that can be a physical manifestation, such as walking and mobility, but also very importantly, this can also lead to cognitive changes over time, cognitive impairment and loss that can lead to increased burdens on the family, on the patient's friends, and also on the economic burden as well, because as our patients become more and more cognitively impaired, they are less able to work full-time in a gainful employment opportunity. So leading up to the burden of MS disease and progression, and really what this means overall. So the new number that we have is about 1 million individuals in the United States are affected with MS. And this is in contrast to an old number that we were using up until about a year ago, which was 400,000. So while we do realize that there is an increased recognition of multiple sclerosis and also the diagnosis of MS, we also do believe that there is an increasing incidence of MS, meaning that more patients are actually developing MS than just being recognized with MS. So that's something really important that we need to be aware of and we need to be addressing. MS is considered the most common cause of non-traumatic disability in young adults, and the majority of untreated individuals with MS develop disability at some point. Whether, again, it is a physical manifestation of disability, such as having weakness in a limb or having trouble with their vision or having trouble with walking, but also with cognitive impairment, depression, intractable fatigue. Those can be equally, if not more, devastating for the patient because it does tend to have impacts on their family life, their home life, and of course their occupational life as well. The national annual cost of MS is between $6.8 to $11.9 billion. So this is certainly no trivial task, and one of the reasons why we are doing our very best to make sure that we are addressing our patients' needs as best possible. And the costs are proportional to the degree of disability, which is, it certainly makes a lot of sense. So, as a person becomes less and less able to mobilize, if they start having problems with being able to think at work, then unfortunately they are at risk of no longer able to work, provide for their family. That becomes an economic burden for their family and also for the economy at large. And of course they have more health needs that are either direct or indirect, and I have some data that I'll be able to show you in a later slide that summarizes that. About 80% of individuals with MS experience restrictions in their activity of daily living. And that includes simple things such as being able to dress, being able to feed, being able to ambulate by themselves. But there's also something called instrumental activities of daily living, which are certain tasks like being able to balance a checkbook, being able to go grocery shopping, and being able to go to work and provide for the family. And 60 to 80% of individuals with MS will have lost their job at some point. So this is certainly an economic burden that we really do need to make sure that we're addressing. And this is actually a staggering number, but only 37% of individuals with an expanded disability status scale score of less than 3 are employed. Well, what does that mean? I'll be going over the EDSS in a minute and exactly what that means. But this basically means that someone who is mildly to maybe moderately impaired, so they're still able to walk around independently. They still have a lot of their own faculties. They might just have a little bit of weakness in an arm or a leg. Only 37% of those individuals are still employed. So, that does highlight the importance of things like intractable fatigue and cognitive impairment, and how are we measuring those things, and how important they are in maintaining one's normal life so that they're able to provide for themselves and for the family. There's actually a 30-year observational study with nearly 900 patients with MS who failed to have a long-term benign course of MS even if they had a favorable 10-year disability score. So basically that means that just because someone is looking like they have a relatively mild disease course from the beginning, if left untreated, that doesn't necessarily mean that they are going to continue to do well in the long term. That over time they may run out of that steam, they may run out of that critical threshold and start to develop that more progressive decline over time outside of treatment. And there is suggestion that the median survival from birth in the MS population is actually less than that of the general population, with a life expectancy that is about 7.5 years shorter. So, all of these things eventually add to the burden of MS on the patient, the caregiver, the family, and of course the economy at large. So I had briefly mentioned the Expanded Disability Status Scale. And basically, this is the oldest and most widely accepted measure of MS disability. And what we have here is a little graphical picture that shows exactly what this means. So the EDSS is a scale from 0 all the way to 10. 0 is the person has absolutely no disability whatsoever. And an EDSS of 10 means that the person has passed away from complications of multiple sclerosis. And what this graphical picture shows you are some critical milestones of the EDSS, where a 1 is only minimal signs but no significant disability, and we can see that in this picture it's showing that the person is still able to run or jog. And then an EDSS of 3 is someone who has a moderate amount of disability, meaning that they're still probably able to walk independently without much trouble, but they may have some moderate limitation, either numbness or tingling or weakness in an arm and a leg, or having trouble with leftover vision from a previous optic neuritis. An EDSS of 6.0 is the use of a cane that they need to be able to walk with, and an EDSS of 7 is essentially who is wheelchair bound, and they're unable to get up and walk more than a few meters at a time without assistance. The problem with the EDSS, and we use this quite frequently in both clinical practice and in research, because an EDSS number in the MS world, it has a very clear objective picture of what that person would look like. But there are some criticisms with the EDSS. Some of those criticisms are that it's really heavily dependent on mobility. So, as I was describing the EDSS picture here, I was really describing someone from walking independently to needing a cane to being restricted to a wheelchair. But it's not, heavily emphasizing fatigue. It's not heavily emphasizing cognition. And if there is someone who is really struggling with those particular limitations, it's not as heavily weighted in the overall clinical score as the mobility aspect. So that's one of the criticisms. The other one is that it's pretty insensitive to small changes that a person might think is clinically significant, but according to the number, it's not, because it's a very small measurable change, and we might not really be able to see it all that well. The other one is it can be very subjective in rating assessments. So my evaluation of a patient and giving them an EDSS score may not actually be the same EDSS score as an MS neurology colleague of mine. They're very subjective measurements that are being done that can be highly scrutinized. So while it does give us an overall picture of the person in front of us, it is not a perfect scoring system. So what this graph is really showing us is a combination of the EDSS and what happens to the cost over time and how that productivity decreases. So, down here we can see someone who either has no disability whatsoever or very mild disability, and the employment rate for this person is going to be very high because they're really not losing much in the way of their physical and cognitive and emotional quality of life, so that they're able to still go to the workplace. However, as the person becomes more and more physically and cognitively disabled, we can see that their employment rates start to decrease substantially with a high disease burden and high healthcare costs. So, we can see that this is a very linear and dynamic problem in patients who are accumulating disability over time, and why it's so important for us to be able to try to prevent this accumulation of disability over time with early treatment. And we can see that here with this graph right here. So if we're looking at time on this x-axis, and we're looking at the levels of disability on the y-axis, so here we're able to see someone who has very little disability and someone who is essentially wheelchair bound. We can see that at the disease onset, if we are able to start treatment very early, then we're going to be able to see a much better outcome over time with far fewer people who are even approaching the need for a cane versus someone who we are not allowing them to start on any disease-modifying therapy, that we're essentially resulting them to the natural course of the disease, who after a certain period of time have an increased probability of developing significant disability leading to a person who may even become wheelchair-bound. So effective disease-modifying therapy has been shown to do multiple things. So one is reduce the frequency of relapses. It also can reduce the number of MRI lesions that develop in the brain and the spinal cord. It can delay the progression of disability, and it can modify the overall disease course. So this is what we really aim to do with our disease-modifying therapies. So looking at disease-modifying therapies and what they're able to do for us. So, right now, depending upon whether you're counting generic disease-modifying therapies, we have about 13 to 14 disease-modifying therapies that are all FDA approved to treat relapsing forms of MS. And some of them are injectable medications, so that includes our glatiramer acetate, otherwise known as Copaxone or Glatoba. And then we have our interferon beta therapies, such as Avonex, Betaseron, Xtavia, Plegrid, and Rebif. And these are all considered our platform medications. And then we have our oral medicines, including fingolimod, including teriflunomide, including dimethyl fumarate. And then we also have our infusion therapies, which are considered our highly effective medicines, meaning that they tend to give the best overall outcomes in patients who have relapsing forms of MS in terms of being able to prevent new MRI lesions and clinical relapses. We have natalizumab, we have alemtuzumab, and we have ocrelizumab. But as I have started down here, the available disease-modifying therapies differ in their efficacy, meaning how well they work, their mechanisms of action, their side effects, and their safety profiles. So this is the importance of being able to have a very real, open, and comprehensive conversation with the MS healthcare provider in determining what is the best therapy for that individual. So I have mentioned a lot of information in terms of disease-modifying therapies for relapsing forms of MS. And up until recently, we really didn't have anything available that was indicated for progressive forms of MS. Well, we have in the MS scientific field, we've been making a lot of progress in terms of looking at available immunomodulating therapies that are specifically targeting the progressive stages of disease, which is something that we've really never seen before prior to a few years ago. In 2016, there was a pivotal clinical trial called Oratorio that looked at ocrelizumab in patients with primary progressive MS. Ocrelizumab is considered a B-cell depleting therapy, meaning that it depletes part of the B-cell line, which are members of the innate immune system, the adaptive immune system that we had talked about earlier in the talk. And by depleting part of these B cells, there may be some positive results in delaying progression in primary progressive MS compared to an active comparator, in this case interferon beta 1A. And specifically, this medicine, ocrelizumab, otherwise known as Ocrevus as a trade name, was able to identify patients who were younger than the age of 50 years and who were also more amenable to active inflammation through gadolinium-enhancing lesions that we felt were more likely to benefit from this medication as opposed to a purely progressive disease form. Rituximab is a very similar medication compared to ocrelizumab in that this is also a B-cell depleting agent. And it was also looked at in patients with progressive MS, and we actually use rituximab not uncommonly off-label for both progressive and relapsing MS. It's just there's some insurance restrictions because it doesn't have FDA approval. But looking again at patients who are younger than 50 years old and with active enhancing MRI lesions in the brain and the spinal cord, it was thought that rituximab actually does have some positive benefit in patients who have progressive MS. And this is one of the reasons that ocrelizumab was looked at so intently in the oratorio clinical trial in patients with primary progressive MS. But then you may be wondering, well, that's great for primary progressive MS, but what about secondary progressive MS? Well, we do have some late-breaking data looking at a medication called siponimod, which is an oral therapy. It's a once-daily pill that is very similar to another disease-modifying therapy that we use for relapsing forms of MS called fingolimod or Gilenya. And it actually was demonstrated in a pivotal clinical trial called EXPAND to potentially be positively beneficial in patients who have purely progressive MS, meaning patients who are a little bit older and who may not necessarily have superimposed inflammation via new MRI lesions on the brain and the spinal cord. So this actually may be a breakthrough in patients who purely have progressive MS, specifically secondary progressive MS, and we may actually be able to help these people. So these results demonstrated that siponimod had beneficial effects on clinical relapses and MRI disease activity, including brain volume loss or brain shrinkage. So, there's a lot of potential for this particular medication. Right now, siponimod is at the FDA. It is not yet FDA approved for the use in secondary progressive MS, but we're hoping that we'll be able to hear back from the FDA by the end of 2018 or the beginning of 2019. So now that we talked about the importance of trying to forestall the progression of disease over time and what our disease-modifying therapies do, let's talk a little bit about the barriers, the pitfalls, and potential solutions. So, one of the common themes of disease-modifying therapies not being able to work at their optimum is when the medication is not being used compliantly or adherently. And there are many different reasons for that, or potential reasons for that. So some of them might be due to the perceived lack of efficacy, meaning that the individual who's taking the medication doesn't think that it's working. And that does mean that there needs to be a conversation with the healthcare provider in terms of being educated in terms of, what are the expectations for this disease-modifying therapy. If the person doesn't feel like it's working, that might mean that the medicine actually is working. So these medicines are not meant to fix symptoms. They're not meant to fix disability. They're meant to prevent more disease activity in the future to forestall progression of disability over time. So there may be a mismatch between what the disease-modifying therapies are meant to do and what the individual who's taking that disease-modifying therapy believes it is meant to do. There may be issues with adverse events, so that may be specific side effects or long-term safety issues that need to be addressed, and of course cost. So if the patient is limited in that they are unable to afford their disease-modifying therapy, that they're unable to seek out patient assistance programs, their insurance company is not paying for the medicine, then the person is not obviously going to be able to take the medication as prescribed. And then there are also other patient-related factors, such as psychosocial issues, meaning that a patient may be in a rural area, they may not have the access to care that they need in order to maintain adherent disease-modifying therapy scheduling. There may be physical limitations, meaning that they're unable to access the medicine because they simply cannot get to their infusion facility, or they're unable to perform their self-injections because of weakness or incoordination of the hands. And of course, system access, which goes back to the cost issue. If the healthcare insurance system is unable to pay for the medicine and they have lack of patient assistance programs. So, unfortunately, it then kind of goes to this vicious cycle where if the person is unable to take their medicine compliantly, they're going to have reduced efficacy. The person is going to feel that the medicine isn't working, and then they might take it even less, and reduce efficacy even more, and it just becomes this horrible tailspin that we really need to try to interfere with early on. So a previous review of numerous studies reported that adherence ranged from between 41 to 88% across injectable disease-modifying therapies. And a global adherence project that actually surveyed over 170 sites in 22 different countries reported that there was about a 25% non-adherence rate in over 2,500 patients who were treated with a disease-modifying therapy for at least 6 months. So this is certainly not a trivial finding, and we need to try to find ways that we can interfere with these barriers to maintain adherent dosing. So it's not a surprise that if a person is taking their disease-modifying therapy as prescribed, it will lower the risk of relapse and disability accumulation and will eventually result in improved self-reported quality of life compared with people who are remaining non-adherent to treatment. And looking at some more data, we were able to see that in over 2,300 patients who were showing gaps in their disease-modifying therapy, about 8% of those were presenting with a severe relapse that was defined as needing high-dose steroids in a hospital setting compared to those patients who were taking their disease-modifying therapy adherently. And then looking at another health claims database that looked at over 12,000 people on 9 different disease-modifying therapies, they were actually able to show that there was a reduction in the hospitalization, the number of emergency room visits, and the likelihood of 12-month relapses, between 35 to 55%. And then we can also see that this reflexively means that there is a decrease in the amount of spending per patient when they are taking their disease-modifying therapy compliantly. And that is overall annual direct medical care costs, the hospitalization costs, emergency visits, and outpatient visits. So we can see that, not only does it have a clinical meaning for the patients and the caregivers and society as a whole, but there's also a reduction in the economic burden as well when people are taking their disease-modifying therapy as they should. So what are some ways that we can, try to increase adherence among users of these disease-modifying therapies so we can have better long-term health outcomes? Well, the MSAA actually put together an acronym called S.E.A.R.C.H. And the acronym is supposed to help folks remember, organize, and prioritize important questions to discuss with the healthcare team. And that actually stands for safety, effectiveness, access, risks, convenience, and health outcomes. And specifically, this is a very nice way of trying to organize one's thoughts so when they go in front of the healthcare provider and either discuss their current disease-modifying therapy or they're talking about a switch to another medicine, they're able to organize in a very efficient way what are the things that are important to me and how does this correspond with my own values so that I can select a disease-modifying therapy in a shared decision-making approach with the healthcare provider so that I'm more likely to remain adherent to that disease-modifying therapy and have better outcomes. And there's actually an MSAA search talk that goes beyond this talk, but is actually quite helpful in being able to deliver some helpful tips in remaining compliant on therapy. So really, it's all about some very basic tips. Understanding the expectations of the disease-modifying therapies. So it's really important to discuss what this means with the MS healthcare provider. What is a realistic expectation for these medications? And as I had alluded to before in some previous slides towards the beginning of the talk, the DMTs are not meant to fix disability. They're not meant to take away symptoms. And, if you are feeling that there hasn't been a change, you don't feel any different on the medicine, that actually might mean that the disease-modifying therapy is working for you. Now this doesn't transcend to all cases, But in the example of someone whose MRIs are stable and they're not having any clinical relapses and their neurological exam is stable, that actually might mean that the medicine is working quite well for that person. And so this is an important conversation to have with the healthcare provider to make sure that the proper expectations are being met. Managing side effects. So, one of the more common reasons why folks do not take their medicines compliantly is because they're just not tolerating it well. And this is going to be important to also discuss with the healthcare team in terms of ways to minimize or mitigate the side effects completely, whether or not that means taking an over-the-counter medicine to help with gastrointestinal symptoms or something for flu-like side effects, so an over-the-counter analgesic, or learning how to rotate injection sites if they're taking a self-injectable disease-modifying therapy. Or if the side effects are intolerable despite your best management strategies, then it's time to have a very real conversation with the healthcare provider in that the disease-modifying therapy may not be for you and to discuss an alternative. And then, of course, adjustments to taking a regularly prescribed medication. So, if someone is going from not taking any medicines to being told that they have to take a medicine every day, every other day, once a week, once a month, depending upon what the medicine is, it's going to be very important to set, calendar reminders or use a smart app or sticky notes or, something to help jog the memory that it's time to take the medicine. There are programs that are available to receive proper training on self-injection techniques for people who are using one of the platform medicines. And of course, if problems come up, please don't just stop your disease-modifying therapy. Please make sure that you are communicating what your needs are to the healthcare provider, so that way your MS is as well protected as possible. So really what this gets down to is the treatment model. And, in the world of MS, we are going from a paternalistic model, which is more of the healthcare provider or the physician informing the patient that this is the best disease-modifying therapy or the best treatment for this particular person, to more of a shared decision-making model where the information recommendations are made by the clinician, but is also putting values and preferences of the individual into the mix and being able to develop a treatment rapport together, which may ultimately result in better compliance on the medication. So what does really this mean? So given the complexity of MS, the healthcare provider and the patient really should work together to understand problems and find successful solutions together. And of course, I always try to invite the care provider, whether or not this is a spouse, if this is a child, if this is a parent, if this is a friend, someone who can help advocate for the person, to being involved in this conversation to help meet the goals of the patient and the doctor together. And it really is important to establish an open and honest doctor-patient relationship with a clear communication strategy. And this will help foster trust between the healthcare provider and the patient to enhance the accuracy of the diagnosis and the treatment, and of course to improve adherence and compliance with the disease-modifying therapy, because if the person who is taking the medicine understands the risks of not being on medicine, understands the expectation of the medicine, and feels comfortable that they can share their fears, they can share their concerns with the healthcare provider, we will be able to help minimize the rates of non-adherence. And increase patient satisfaction, reduce complaints, absolutely, and best possible health and overall quality of life, which is the overall goal of what we're doing together. So the take-home message: MS is a heterogeneous disorder that is pathophysiologically defined as an autoimmune, inflammatory, demyelinating, and neurodegenerative condition. There are many parts to MS, and there's a very complicated, complex, and sophisticated interplay between genetics, between the immune system, and between potential environmental triggers. MS is associated with a high burden on the patient, the caregiver, family, and economy, and increases if the condition remains untreated. Disease-modifying therapies prevent disease activity, delay long-term disability, and modify the course of MS with better success rates if they're taken adherently. And a shared decision-making model between the patient and healthcare provider improves healthy relationships, trust, and the opportunity for successful MS treatment. So that concludes the formal slideshow, and at this time I would be happy to take questions from the audience.
Well, thank you so much, Dr. Hersh. That was an excellent presentation, very comprehensive, a lot of great information. So we're so pleased to have you present tonight, so thank you so much again. We had a ton of great questions that poured in through the hour, so I'm going to take a few minutes and we'll get to as many as we can. There were two questions that were similar, so I'll read both questions and then you can address either one or both together. The first was, what else can patients do for their MS in addition to taking a DMT? And then I think a related question is there an advantage to taking vitamin supplements with one's DMT when approved by a doctor?
Oh, these are excellent questions. So first of all, I want to thank you, Peter, for having me tonight, and I thank all of the attendees for their attention, for their amazing questions, and of course to those people who will be able to tune in offline. To answer your question, so I'll answer the first question. The first question is, what are some other things that individuals living with MS can do to improve their quality of life and even their function outside of disease-modifying therapies? Yeah, so great question. I usually approach this as a four-arm treatment approach. So the first thing that we talk about, obviously, are the DMTs to prevent worsening disease over time. But then, we also have steroids, and high-dose steroids tend to be used for patients who are coming in with relapses or enhancing lesions on their brain or their spinal cord. And really what the steroids are meant to do, they are meant to hasten the recovery time, shutting down the active inflammation a little bit more quickly than in someone who is not treated with steroids. So steroids don't really provide any long-term meaningful benefit for the overall MS disease course. It really is meant to hasten the recovery time for a relapse. So that's another way that we treat MS. Another way is symptomatic therapy. So as I had alluded to in the presentation, these medicines, these DMTs, are not meant to improve symptoms, so we do have to rely on other strategies. And some of them may involve certain medications, like neuropathic pain medicines, and some of it doesn't rely on medicines, like neurorehabilitation, either with physical therapy to help with mobility and gait training, or occupational therapy that may help with hand function, may help with cognitive rehabilitation, and also with safety functioning in the household. And then there's speech and language pathology rehabilitation that can also be utilized. And then, of course, lifestyle healthy behaviors. So really encouraging our patients to eat well, to exercise, to make sure that their psychological and emotional wellness needs are being met, and to work closely with the healthcare provider and the primary care provider in minimizing other comorbidities, specifically vascular comorbidities. So there's been a lot of research showing that things like high blood pressure, diabetes, obesity, high cholesterol, smoking, they can all increase the risk of disease burden over time. So really having a nice regimen in place to help try to control some of those comorbidities are also instrumental in overall treating our folks who are living with MS.
Okay, excellent response. There were several questions in and around the difference between RRMS, relapsing remitting MS, and primary progressive MS in terms of how they are classified, the differences between them. One person wrote that her doctor said that once you're diagnosed with RRMS, you do not progress. So could you kind of touch on, I know you had a pretty good slide on that.
Yeah, I'm going to go back a little bit. Let me find that slide. Getting close. Here we go. Okay. So this is the natural history of MS, and I probably didn't do a very good job of explaining it before, or I can at least maybe finesse it a little bit. So what I was alluding to before is that instead of putting a lot of emphasis on the term relapsing, remitting, secondary progressive, primary progressive, what we're really trying to do is we're trying to hone in on the people who have relapsing forms of MS, meaning those people who are still having active inflammation that is either being clinically manifested through an exacerbation, through a clinical relapse, or through new MRI lesions on the brain of the spinal cord. And the reason why we are really trying to hone in on that definition is because our available disease-modifying therapies do a much better job of controlling for that than for the more purely progressive MS over time that is reached after a critical threshold after about 15 to 20 years of not being on an MS therapy. So the difference between secondary progressive MS and primary progressive MS is that in secondary progressive MS, the person starts to accumulate disability more slowly over time, either with or without relapses, but this is after a relapsing remitting disease course. In primary progressive MS, which is not really shown on this particular graph, but it's a slow accumulation of disability over time without an initial relapsing remitting disease course. But what we're really trying to hone in on are all these people, are they still having new inflammation that may still be amenable to some of these disease-modifying therapies, or are they purely progressive where we might have a harder time of being able to hone in on the disability because they are more prone to that neurodegenerative loss, which unfortunately is irreversible. So this is why we put a lot more emphasis on treating as early as possible so we can delay and maybe even prevent the progression of that disease altogether. And I hope that I was able to answer that question a little bit more efficiently.
Yes, that was excellent. And I kind of related to that. There were questions about are there any other medications for PPMS other than Ocrevus and people being PPMS for a long period of time, and even after 30, 40 years, is it still a viable option to try these medications?
Sure. Well, we also have to keep in mind that, as I had alluded to with the rituximab data, and it's the same thing with the ocrelizumab data. Let me see if I can get to that slide again so folks can read it. Is that the studies that were looking at these B-cell depleting therapies, that they were actually studying these patients who were on the younger side. So these patients were 50 years of age or younger. So, there potentially is a difference between younger patients who are still having active lesions in their brain or their spinal cord and their response to ocrelizumab and rituximab, as opposed to people who are in their late 60s, early 70s, who have a progressive disease course. They may not respond in the same way. So we really have to be careful of extrapolating the clinical trial data to real life.
Okay, great. You had touched on the EDSS scale and some of the issues involved that. So a person wanted to know, are there other scales for measuring disability? And they mentioned about in the office they get a reflex test, they follow the doctor's fingers with their eyes, they repeat information backwards. Are all of these scales, I guess, related to the EDSS scale?
Yeah, excellent question. So What you're referring to is a neurological examination, and a lot of those components are actually used to put together this EDSS. But yes, to answer your question, there are other scales that are used either with the EDSS or in addition to the EDSS in order to better capture some of these other domains that are not really being captured in the EDSS. And one of those is called the Multiple Sclerosis Functional Composite. And that actually takes 4 different domains, and numbers are provided to give, in my opinion, a little bit more of a general overview that isn't just highlighting mobility, but is also highlighting other things. So one of them is called the Time 25-Foot Walk, which, yes, it is a measure of walking ability. And essentially what that means is how long does it take a person to walk 25 feet. And in a lot of MS centers, the Time 25-Foot Walk is directly integrated into the neurological exam because this is a validated objective measure of walking impairment. But it also looks at other things, such as manual dexterity, and we do that through what we call a 9-hole peg test. So this is the ability of a person to place pegs into 9 different holes and then take them out. And how long does it take for the person to do that with their dominant hand and their non-dominant hand? And that is another objective measure of looking at manual dexterity. Then it also brings into account their visual acuity. And there's something called the low contrast visual acuity test that is integrated into this MSFC that is a measure of how impaired are they with their vision. And the last one is, before we were using what we call the PACE-SAT, which is the PACE Auditorial Serial Addition Test, which is a person's ability to be able to add together subsequent numbers. But we've actually been starting to incorporate an additional test called the Symbol Digit Modalities Test, which is, in my opinion, a little bit easier because it's more visual. And essentially, it's the person's ability in 90 seconds to be able to match a number with a provided symbol. So all of those 4 components do a better job of being able to integrate, yes, motor impairment in terms of mobility, but also their manual dexterity, their vision, and then a processing speed test, which is a validated measure of cognitive impairment in folks who are living with MS.
Okay, great, excellent. There were a couple questions, I believe, around MRI. One was a direct MRI question, and the other, I believe the answer would be MRI. So the first question is, how is brain volume measured? And then the next question is, if brain MRI is stable, no new lesions, could there be active lesions on gray matter that we cannot see?
Oh, wow. These are great questions, and I really applaud the audience. These are fantastic. So the first question, how do we measure brain atrophy? Well, that is a great question. And we are actually trying to incorporate measures both on conventional MRIs, which are the MRIs that folks can get done in the community as part of routine practice, and then also using research MRIs, which are not routinely being used in clinical practice, but we're using on research scanners to try to acquire more information on how we can measure it. There are different measures for progression of brain atrophy. Some of it is called a brain parenchymal fraction that we use, which is a measure that we're starting to use a little bit more commonly using conventional MRIs. We are starting to look at thalamic volume, which is a gray matter structure in the middle of the brain that is very important for essentially being the central processing unit of the central nervous system. There's a lot of inputs and outputs from these nuclei, which allow the person to function normally. So a lot of pathways going in and out of the thalami, which are now starting to be measured as gray matter pathology. We're also looking at the basal ganglia, looking at caudate atrophy, looking at ventricular width. So, there are many ways to measure brain atrophy, whether it's global brain atrophy, meaning the whole brain, or just looking at specific areas of the brain in terms of gray matter pathology. And, some of these things are being incorporated a little bit more in conventional routine use, but others are still very much, being tested on research MRIs. A question about if a brain MRI looks stable in terms of new T2 lesions, gadolinium-enhancing lesions, is there the possibility that there can still be gray matter problems? And that is an excellent question, and the answer is yes. So our conventional MRIs do a pretty good job of looking at periventricular lesions, looking at lesions in the back of the brain called the posterior fossa, the brainstem, the cerebellum, and looking at the spinal cord. We are able to see juxtacortical lesions. These are lesions that are kind of abutting the outside of the brain, but they don't do a very good job of looking at cortical lesions unless you are using a brain MRI with a high resolution. And there are 7 Tesla MRIs that are being used as a research tool that does a better job of being able to actually look at the cortex, which is a gray matter structure. And we're actually able to pick out those cortical lesions. But if you're having an MRI done on a 1.5 Tesla magnet, which is not a very high resolution quality, those can easily be missed. And then there's also the question of if MRIs are being done on different scanners and the number of slices are low, meaning that you're missing a lot of brain territory because the cuts are too big, then it's going to be very easy to miss MRI lesions. So what I try to educate the patients on is, let's try to get the MRIs done on a high quality MRI as possible. So 3 Tesla is my magnet of choice, and really to try to use the same scanner as much as possible with the same sequence protocol, so that way we're able to compare those MRIs as reliably as possible so we're not missing anything.
Great. Thank you so much for that. And one last question, and someone said they live in a pretty rural area but obviously still want to get good health care even though that's challenging. And they wanted to know how they can get connected to an MS neurologist and stay connected over the period of time for treatment and care.
Yeah, so what we're really trying to do in this day and age is really improve access to care. And that includes people who are living in inner cities, who are living in rural areas, where they may not have the same access to health care as people who are living in the cities. There is something called telehealth or virtual visits, whereby, depending upon the institution where the patient can get to, may actually be able to see an MS neurologist, simply through their computer or through their smart handheld device. And this is called telehealth. And it's becoming a lot more popularized in healthcare across the spectrum, simply because, we have these amazing internet tools and technological feasibilities. One of the caveats is that through telehealth, the healthcare provider generally does need to be licensed in that particular state where the patient is calling in from. And usually it is required that the patient at least has a face-to-face visit with that particular provider. But if the person is able to identify an MS healthcare provider, either through the MSAA or through the help of the National MS Society through their Navigator program, they may be able to coordinate a face-to-face visit, a one-time visit with an MS healthcare provider, and then use a telehealth option for consultations on a more routine basis, while also inviting a local general neurologist to oversee care in between those visits. So, this is something that we're really trying to popularize more and more to make sure that we are reaching out to our patients who may be limited in their accessibility to health care.
Well,
and I also want to make sure, Peter, because I remember that I didn't answer a question that was posed before, and I want to be able to make sure I answer that question. I think it was the first two questions that you had asked me in terms of what patients can do for their MS besides the DMTs, and I didn't answer the vitamin piece.
Sure, go ahead.
So to make sure that I'm addressing that, so the person who asked isn't frustrated, we have to be very careful about supplements. And the reason for that is because a lot of supplements don't abide by the same FDA consumer registration and regulation as prescription medications. So any supplement, it is very important to discuss it with the healthcare provider to make sure that if they are using something, that it is being used safely. And a lot of supplements are not studied to the same breadth as some of our prescription medications, and because they don't, they're not part of the same strict regulation with the FDA. They may not all be considered safe, and people might be spending a whole lot of money on these agents that really aren't doing anything. In terms of vitamins, so if I'm going to make a suggestion on any vitamin whatsoever, it's the vitamin D. And the reason for that is because of what I alluded to in the beginning of the talk, is that vitamin D deficiency may actually be a potential trigger for patients who are genetically predisposed to developing MS. So, not only is it important to make sure that those vitamin D levels are supplemented at least to the normal level, but there is some research showing that, pushing that level a little bit higher may actually have some additional benefits. Now, of course, I say this with great caution, and that anyone who is starting a vitamin D supplement, that it is discussed with the healthcare provider, because there is such thing as too much vitamin D and vitamin D toxicity that can cause renal failure. So levels do need to be completed in order to make sure that the levels are appropriate to the amount of vitamin D that is being supplemented with, and to make sure that this is done through the care of a healthcare provider.
Excellent. Well, thank you so much for that response and all of the responses and the presentation, of course. That was just tremendous amount of information and resources, and we are so glad and grateful to have you joining us tonight for the program. So that does conclude tonight's program, Understanding MS Progression, the Importance of Treatment Adherence. As I had mentioned, this program is being recorded tonight, and it will be archived very soon on our website, which is mymsaa.org. And as I mentioned, just big shout out and thanks to Dr. Hersh for an amazing job tonight. And I do also want to thank our program supporter, Sanofi Genzyme. We have a brief survey that immediately follows the conclusion of the program, and I would ask people to just take a moment to complete the survey and allow us to know how we did tonight and topics for future webinars as well. So on behalf of MSAA, thank you so much for joining us, and have a great night.